Today we're going to be focusing on the Asian and Pacific Islander community. I'm really happy that we were able to recruit several of our presenters today. They have been very active in the community for many years, and so I'm really looking forward to them sharing a lot of what's been going on for them in the community. Our presenters for today include Michael Byun with Asian Services in Action, Juma Arkaria and Sarah Miller with Community Refugee and Immigration Services, Buntan Pamase, she's with Diversified Health Management. We have Christina Gilpin, she's a youth and young adult. And also Shanta Belaswamy, who is a professor at The Ohio State University and the president at Asha Ray of Hope. We will proceed with our first presenter. Introduce you, welcome. Michael B.
And thank you for having me here, and I want to talk to you a little bit about the organization that I work with, as well as give you some information about the different programs and services and couch it within the context of some of the key trends or issues that I see and our organization sees in the community. Asian Services in Action was founded in 1995 by 4 Asian immigrant women in the Akron area. Initially, we started out with a modest little health screening fair. What the women didn't realize is that when they organized this fair, they were hoping for maybe 20 folks to show up. They had nearly 100 people show up. So it was a clear indication that there were some great needs in the community that our organization could address. The organization annually serves over 10,000 individuals, primarily in northeastern Ohio, which is comprised of Akron and the Cleveland area. The work of our organization is twofold. We focus on empowering our communities through programs and services that are linguistically and culturally appropriate, but we're also involved in advocating on behalf of our communities. So advocacy is a very integral part of the program delivery work that we do at our organization. And one of the things that we pride ourselves on is the fact that we deliver care and services in partnership with our communities and our community leaders and others in a culturally and linguistically appropriate way. And I think that's our important niche as an organization. We do work across the state, working with different pan-Asian, ethnic, and other organizations who do social services and other work in the community. And our partners here in Columbus, for example, is the Asian American Community Services. We work with the Ohio Asian American Health Coalition. In Cincinnati, we work with Asian Community Alliance. In Toledo, we work with Asian American Council of Chinese Council, and to just name a few. Our program areas are divided into 5 different integrated departments, and I want to go ahead and list them, and then I'll go into just a brief detail on a couple of them as it relates to today's presentation. They include self-sufficiency, which is focused on workforce employment area. Children, youth, and family, which looks at family resilience, looking at youth empowerment and other programming. Aging and adult services, focused on wellness and socialization issues and public benefits access issues for our older adult population. Community health promotions, we are the first in the state of Ohio to have a federally qualified health center focused on the unique cultural and language needs of Asian Americans and Pacific Islanders, and it's based in Cleveland's Chinatown area. And the last area is what we call cultural outreach, where we focus on interpreting and translation and other language access needs. Just a little bit on the demographics, and I know the rest of the speakers will be touching upon the different communities here in the state of Ohio. Overall, in the state of Ohio, we have over close to 250,000 folks identified as Asian Americans and Pacific Islanders. 2%, it's around 2% of the total population. And from 2000 to 2010 census, we are the fastest growing in the state of Ohio by 49% during that decade. And more than 4,000 of refugees are here in the state of Ohio since 2001. So we are a really important place, and I think Chris will talk a little bit more about the refugees, but we're an important resettlement state for refugees. And the difference between refugees and immigrants is that refugees are not coming here by choice. They're leaving, escaping, fleeing areas that are war-torn conflict areas in their homeland, where they're facing persecution, violence, and other issues. And so on the on the invitation of the State Department, they come to the United States and work with, at the national level, what are called VOLAGs, voluntary agencies, and there are several across the country that work with then host sites within different states that have satellite sites, and they're resettled. And so Columbus is one area, Cincinnati is another, and Cleveland is yet another. In northeastern Ohio, about 1/3 of the total state of Ohio's Asian American Pacific Islander population reside in the northeastern Ohio region. We have the 5 major ethnic groups are Asian Indian, Chinese, Filipino, Korean, and Vietnamese, which wasn't listed on the PowerPoint, are the top ethnic groups here in the state of Ohio. And as well as in our region in northeastern Ohio. So as far as issues and current trends within the Asian American Pacific Islander communities, I want to highlight 5 different areas. One is alcohol, tobacco, and other drug, suicide, obesity, gambling addiction, and trauma. So the first area in terms of alcohol, tobacco, and other drugs, ATUG. If you look at data that's been disaggregated, you will see a variance in difference in terms of prevalence rate of drug use and tobacco and alcohol use in different ethnic communities. And so one of the things that I want to hit home, and it's important take home for you all, is that don't clump the Asian community as one, because when you do, the data shows that we're thriving, we're doing great. But the reality is, if you disaggregate the data and look at different pockets of ethnic Asian communities, it's dramatically different from one community to another. And we see those disparities, especially in health and mental health issues, among Southeast Asians and some Pacific Islander communities. For example, a youth survey in the Bay Area showed that 40.8% of underage Asian youth used alcohol, which is substantially higher than the national norm. And that's really important to understand and recognize. And these youth are primarily from South Asian, Southeast Asian population, Cambodian, Laos, Vietnam, Vietnamese, Hmong, to name a few. So as part of our organization's work on alcohol, tobacco, and other drugs, we have a program called the International Community Empowerment Project, which is Asia's longest running after-school, summer school mentoring, acculturation, and ATOD prevention program. And it's been highly successful in building youth resilience, and also have shown good data to show that youth are delaying the onset of use of tobacco and other drugs, or completely abstaining from it during their adult life. So we feel this is a really important program, and we work with the drug boards in Cayuga and Summit County on that project. The second area I want to talk with you about is suicide, and this is a very grave and emerging issue in the community, specifically in refugee populations, and within that subgroup, Nepali communities. What we've noticed is that there has been some very strong concerns with the Nepali community. We started seeing this in around November of 2013, where there was an older Nepali man in the Summit County area who completed a suicide. And then in evaluating further the trends, we see within the region, there has been 5 total that I'm aware of, as well as 2 additional attempted suicides within that specific ethnic community. For this community, the Nepali refugee community, suicide culturally is a viable option. So if they have exhausted at least 1 or 2 options to seek help, the third option of suicide is a viable, culturally understood option. And so that's a real concern for the mental health providers in the area, to fully understand, how do we address this unique culture where there is a culture where taking of one's life is a viable option, a solution to a situation. So as part of this effort, the communities as well as our organization have worked closely with the ATOM board in the respective counties in Summit and Cuyahoga to look at developing a proper process for screening and doing early intervention. Then looking to explore further in terms of services that are necessary to support this community and others, especially those from refugee and immigrant communities that face acculturation issues and other associated matters. The other area, before I go into the area around obesity, I do want to talk about why suicide is a concern. It seems to be based upon our assessment of the communities and talking with community leaders. It's really an issue around self-sufficiency, and there's a particular donut population that is greatly impacted. And within the Nepali community, it is this older population of working adults who are not yet necessarily eligible for Medicaid and other public assistance as seniors, who have very difficult challenges in securing seeking job. They have a language barrier that further prevents them from becoming self-sufficient and being able to support their families. And this is a really critical population that I think there's some opportunities for the mental health providers to work closely with those in the workforce development area of services, such as with Jobs and Family Services, to explore some innovative options, perhaps some job clubs specifically targeting this age group and this ethnic group. In terms of obesity, I think this is really important to highlight as far as obesity within the immigrant and refugee communities, because we see comorbidity of depression with issues around chronic disease. And I think it's very common. I mean, it's not just an isolated situation in the refugee and immigrant community, but broadly in the broader community, this is also an issue. But one of the things that's very important to note is that those who are just newly arriving, they're at a substantially high risk for type 2 diabetes based upon assessment and BMI and other risk factors. One of the things that we've noticed is that the refugees and others who are newly arriving have this amazing sudden access to cheap, inexpensive, highly processed food. And that's fatty, that's high in sugar, that's a viable alternative, especially for those who are low income, as an option. And so what we see is that there's higher level consumption early on that are tied to their socioeconomic status. And as they spend more and more time in the United States in acculturating, you will see that the trend will diverge based upon socioeconomic status. So if they increase in income, they're going to move closer towards the general population as far as chronic disease risk factors are concerned. In an effort to address this and other health issues in the community, as I mentioned to you earlier in my presentation, our organization established the first federally qualified health center focusing on Asian American immigrants and refugees in the greater Cleveland area. And we call this the International Community Health Center. And we opened our doors in November 2013, and we're really proud of this project because it serves a very important need in the community. The other important project that I want to highlight that our organization is working on is we have a multi-year funding from Center for Disease Control and Prevention to focus on healthy eating and active living, policy systems, and environmental change. And we work with a multi-sector collaborative group that's comprised of ethnic voluntary-based social organizations, ethnic cultural language schools, 2 community foundations, a community development corporation, and a county public health department. And it's an effort to address broadly at a high level strategies to improve greater consumption of healthy food options and increase physical activity. The next page just shows you our health center, which is again located in the Cleveland, Asiatown, Chinatown area. If you're ever in the neighborhood, please, I'd encourage you to stop by and check us out. The next second to the last item that I want to talk to you about is gambling addiction. There's some pretty alarming statistics in this area too, and how it uniquely impacts our communities. And the American Psychiatric Association recently reported that 20%, 1 out of 5 Chinese Americans have problem gambling. In addition, if you look at Southeast Asian communities, like I said to you before early, the importance of disaggregation of data, because when you separate the numbers, you see that certain issues, health disparities, disproportionately impact certain ethnic communities. And in this particular case, Southeast Asians, over 59% of them are considered pathological gamblers, and that's by the same citation, American Psychiatric Association. And there's a reason for that, and I think this quote from a Chinese gambler really speaks to that. And basically, we have this saying in Chinese, if you don't gamble, you don't know how lucky you are. And so there's this culture of, luck and, challenging your luck in whatever setting. And so that's an important cultural factor that kind of contributes to this concern around problem gambling in the community. We're working very closely with an organization up in northeastern Ohio called Recovery Resources to build and develop a gambling prevention program. It's a multi-phase effort. Our first year this year, we're focusing on outreach and doing some prevention work through workshops and activities, developing some culturally specific materials to disseminate to the community. Our long-term goal is to provide greater resources, specifically additional treatment specialists, certifying bilingual treatment specialists who can provide this service. The last area that I want to focus on is area that's concerned around trauma for war and other domestic violence issues as it relates to victims who are coming from war-torn areas and those victims suffering from domestic violence and sexual assault. The statistics, again, is very alarming. Again, the trends that I've highlighted are things that I and our organization believe are disproportionately impacting the Asian Pacific Islander community. From a recent United Way Greater Cleveland report, an estimated close to 5,000 Asian Pacific Islanders have been sexually assaulted. And then this is within the context of that report where 60,000 victims of domestic violence were reported in this report. However, only 552 of them were identified as API. So one of the concerns is that there's a high level of underreporting going on within the Asian Pacific Islander community, which does not speak to the true scale of the concern in the community. There are a couple of other information points that I want to share with you as it relates to this issue. National study shows that 42% of Korean Americans experience sexual assault or physical assault. In the South Asian community, we're talking about Asian Indian, Pakistani, Bangladeshi. Those communities, we see 40.8% of the South Asian women face physical sexual violence during their lifetime. So these are grave concerns that I think it's important for providers in the community to be aware of as they work with the different Asian Pacific Islander communities. As part of our efforts at our organization, we have two critical programs. One is focused on Hmong women. Hmong are communities from Laos. They're refugees. They were the ones that helped the U.S. military during the Vietnam War. And so as part of their work with us, they've been persecuted in Laos, and many of them have fled Laos to come to the United States and other countries. And so the women that were part of the community have suffered a great deal of violence, including rape, and we are offering this unique cultural therapeutic group that's focused on a cultural heritage and practice, which is weaving, that's intergenerational, working with young women and older women. The other one that we are very proud of is an initiative called the Northeast Asian Women's Leadership Initiative. And this is working with various Asian ethnic women's associations and auxiliary groups. And we empower them to develop their leadership in the area around domestic violence, sexual assault, so that they can tailor interventions and support specific to their respective communities. So we're working with Asian Indian community, Korean community, Chinese community, refugee community, Vietnamese community, and so forth, for them to empower them to develop unique interventions that work in their community. So it's not like this one, general intervention that we tell folks go and implement. We actually work very closely with them to determine what those interventions are. For example, in the Korean community, one of the ways that they address, because DV/SA is such a taboo subject, they're not likely to seek help if you put that out there. However, they're couching it within financial literacy and financial empowerment and using that as a vehicle to reach victims of domestic violence. So that's just one good example of the work that we do in that project, the NALI project. So that's what I have, and I'm sure there will be an opportunity for some Q&A. But again, I want to thank you again for having me here.
So one of the things I want to say, I can't express the importance of why you should be here and why other staff from your individual organizations should continue to enhance your understanding about specific disparities impacting Asians. Just to throw out some things, I'm sure our presenters are a little bit knowledgeable about this. Per our Office of Quality Research and Planning, about a third of the individuals in our system are retained in services. So when it comes to populations like Asian, Pacific Islanders, know that those numbers can tend to be worse sometimes. In fact, we know that many people aren't even coming in the door when you look at other data. It's very difficult because of stigma for individuals to come in and want to use the services. We're also finding, with respect to the Asian community in our regional psychiatric hospitals, are that Asians are staying longer and they're being most likely to be back in 30 days. This rate is higher than any other population in our system. So that's important to know. So that's why it's important to have some of the programs that were just mentioned, like the screening and early intervention. We need programs initiated by the community so that they can go out and be trusted messengers, so the folks feel a little more at ease utilizing services available to those in the community. With that, our next group of presenters come from the Community and Refugee Immigration Services, and they are Juma Arkayer and Sarah Miller.
We are happy to be here and honored to share on this panel. So we are from Community, Refugee, and Immigration Services, like Jomaya said. I manage the Health and Wellness Program at CRIS, and we'll talk a bit more about that program further on as it's a response to some of the needs we see in the community. CRIS in general is a refugee resettlement agency and been operating for about 30 years. It started as like free legal assistance in someone's basement and developed from there, and now we resettle about 600 refugees per year. The three major groups that we are resettling now are Iraqis, Nepalis, and Somalis, in roughly a third each for those groups. And then we have small numbers of other populations coming as well. It's important to note that CRIS is not the only refugee resettlement organization in Columbus. There's also Us Together, which resettles about the same numbers as we do, and World Relief, which is a much smaller, newer resettlement organization. So within CRIS, one major aspect of what we do is resettlement, and that includes getting cases from overseas. Talked a little bit about the resettlement process and how that's people are registered with the UN and then down through the International Organization for Migration, through the State Department, and eventually to Columbus. So that is a big part of what CRIS does, providing core services within the first 90 days after arrival. And Juma is a case manager for Nepali speakers, so he can talk more about what that entails. But it includes providing basic services, housing, getting kids enrolled in school, enrolling clients in benefits, and things like that. Then CRIS also has legal assistance. There's 2 immigration attorneys at CRIS that can help with a range of different immigration legal issues. We have family services that include Help Me Grow and a limited English proficiency parenting program. We have employability programs, and we have the wellness program. So we're going to talk a bit about a specific community specific to this panel, the Nepali community, which is large and growing quickly in Columbus. And then we'll talk a bit about our program specifically and then open for any questions at the end. Okay.
All right. Thank you, Sarah. Well, my name is Juma Acharya. I work with Sarah at Community, Refugee and Immigration Services as a case manager for Nepali-speaking population. I've been working since 2012, primarily with Nepali-speaking population. As a case manager, Sarah has briefly explained about what usually we do. Once we get the information from the State Department saying these refugees are coming in that particular time, we work about with the families who are already here. If they have some family members here, we get in touch with them, talk to them about their families, when they are likely to come, and what do we do to them on their arrival. Then once we set up with that channel, then we look for working with apartment complexes to find housing, then schedule their appointments to Ohio State University screening, then also for other core services that we provide within the first 3 months of their arrival. Once the refugee is scheduled to come, we'll get a notice from our national BOLAC, and they will notify us the local time. We go to the airport with the family members and welcome them and bring them back to their apartment, teach them, give them basic orientation about how to use various things in the apartment, because these refugees are coming from a refugee camp base. So their background is, I'm a refugee, so I know what a refugee camp looks like and what is the life in a refugee camp. So we teach them everything, basically using the toilet to how to use stove, then even switching off and on the electric assets. So this is basically the first important thing that we do for them, and actually the first 1 month of their arrival is the most hardest time for every refugees, because they need to get used with all the system in the sense like daily living systems, also with the very limited language they come with. We have to assist them so much, and we are almost with them every other alternative day to give them as possible services as we have. Then once they are here for about a month, we do them orientation. We have our own cultural orientation classes that goes every Monday, where our instructor, who is here with us today, will be giving a basic overview of the orientation program and basic information about life in United States. Then once they are there for a month, they are more or less cultured with Americans' living styles and all. But as Michael said, I still remember, these people are coming from such a fragile situation. It's very difficult for them to pick up all these things within a short span of time. I've been working since 2012, in fact 2011 when I came, and the first family that I took over, I am still helping them. They still don't have any language, like they don't speak English. Their kids are in the school, but still the family is in need of help. So we keep in touch with the families, but our primary time for, helping these families are first 3 months, which is what we call R&P time period. And thereafter also we'll follow with the families. And we will follow with them as long as they need the service. But some of the service will slowly get saturated as in time passed. So that is basically what we do. And lately, since 2000, Bhutanese Nepali population started coming to the United States since 2008, and this is, I think, one of the fastest growing population in Columbus, Ohio. I remember Michael saying around 4,000 refugees, but to our general assessment, we have around 18,000 and plus Bhutanese refugees who speak Nepali language in Columbus only in Franklin County. So we still have a lot of other counties who have refugees around, and like Nepalis are very predominantly in Columbus and also in Akron, Cayuga Falls, Cleveland, and Dayton and Cincinnati. So we have really a large population in Columbus, and there is a very high need of the services for these very new coming populations. So we have lots of services. As Sarah will be explaining more about the health and wellness program.
And we can just clarify when we say Bhutanese Nepali. I know many people are confused. Is it Nepali? Is it Bhutanese? Is it both together? So do you mind maybe explain quickly?
Sure. Yeah, like if you catch 3 people from the community and ask them where are you from, one will say I'm from Bhutan, the other will say I'm from India, I'm in Nepal, and someone will say I'm from Bhutan, but I am from also Nepal. So it's a very confusing thing, because this Bhutanese Nepali term is like, we are by nationality we are Bhutanese because our nationality is Bhutanese. We are from that country. We are evicted from Bhutan and end up living in a refugee camp in Nepal. So our culture is like Nepali culture. Because of the ethnicity, we are called Nepali. That is why these two words are like, these two nationalities are tossed together to make one nationality. This Bhutanese Nepali are those Bhutanese who speak Nepali and are evicted from Bhutan.
Yeah, so if you see these terms, you can understand they're referring to the same population, and that the common language is Nepali.
And many of them, they say I'm Nepali because like a boy who was born in refugee camp would never say I'm from Bhutan because he doesn't know anything about Bhutan. But for me, I would prefer to say I'm from Bhutan because I was brought up in Bhutan. So
we're gonna just talk a bit about mental health and some of the factors that can affect mental health, both pre-resettlement and post-resettlement. So in Nepal and then here in the U.S., and then talk about how we are working to address some of those factors. Michael talked about the high rates of suicide, and that is really an ongoing concern that we have for this community especially. So I'll talk and you can just jump in. Or you want to talk? Okay. So some of Juma mentioned the life in the camps. It's very different than what people are exposed to when they're resettled here. So the traumatic factors that people are exposed to are completely separate. So pre-resettlement, living in camps in Nepal or in Bhutan and then fleeing to Nepal, they include a sense of hopelessness. I think the average stay in camps is 17 years, is what I have heard. So and sometimes longer, right?
Average, yeah.
So the toll that can take on emotional well-being, self-esteem is huge. Not knowing how long, several failed rounds of peace talks, maybe gaining hope that things will be resolved, people will be able to go home to Bhutan, to their home country, and then that hope crashing again and again, and the effect that has on people's self-esteem and overall functioning. Difficult relationships with the host community, so tension between Nepalis living in Nepal and then the refugee community and law enforcement as well. Lots of mistrust and fear. And we see that transfer in life in the U.S. as well, with people being unsure about the role of law enforcement here, whether that is something you can trust, how to draw on that as a resource, inability to work. So that is huge for any refugee camp population. You can imagine for ourselves the ability to work and to feel like we are contributing and giving back to your community, to your family. That is a huge part of your functioning as a person. And if that's taken away from you, you're very lost and unsure of your basically self-image. So having an inability to work or having to work illegally, being unsure how that will affect your status and your stability with yourself and your family, very unstable. Education, often people are coming with education, but the quality is maybe across the board. You can speak more to that.
Like basically at the initial phases of the refugee camp, when it was established around 92, the camps, they didn't have even education. There were no schools. I was one of the first volunteer teachers who started school in late 1992. I was a small schoolboy, actually. So at that time there were no schools. So a certain age group of the people who were compelled to leave the school back in Bhutan never got a chance to go back to school. I never got a chance to go back to school after I left my 9th grade. I was in secondary school when I was in Bhutan. So thereafter I never got a chance to go back to school, like regular schools. I did my education through all online thereafter. So after 5-7 years of the establishment of the camps, the school, there was a better education centers because this was being overtaken by UNHCR and like other like Western organizations for education. The schools were established, there were teachers, but the teachers were all volunteer teachers who were like, at the most, highly qualified would be a bachelor degree. There will be hardly 1 or 2 bachelor degree holders, teachers among the population, like 50 teachers in a school. So all these teachers were having an educational background of like grade 10 or grade 12 at the most. So these were the teachers, and these teachers were never trained to teach in the class. They were all volunteers, and they were being paid like 500 rupees, which is equivalent to $6 per month. So this was what the initial phase was. But in between, like in around like 2000, let's say 98 to 2005, the schools were so well established. The UNHCR started paying more money to education sector, and there were schools. Those students who passed in very good scores would be given a scholarship to go to the local schools, local colleges, private colleges to carry on with their education. But when this resettlement started, when the rumor of the resettlement process came to the camp, then most people were not interested to apply for this process because of the feeling that, well, we won't get a chance to come back to our country and we are lost, our culture is lost, our everything is lost. You can just imagine, like, if you are thrown to Nepal from here for the rest of your life, then you can just think, well, that is the end point. So you are put somewhere in the black hole. So everybody start thinking, I'm not going, I'm not letting my families to go, no. Then there were this process, the resettlement process gave a kind of like break in the school system also. Students started feeling, well, if I'm going to United States, there is no use of studying here. I'm studying here all this Nepali education, all this Bhutanese education. I'm not going to make use of anything back in United States. So most people started dropping out from the school. So after 2008, there is a drastic fall in school dropouts and the quality of the education also, because first person who applied for this resettlement process were educated a lot in the refugee camp. So these educated teachers who had a bachelor or master degree in teaching in refugee camps applied for the resettlement process, and they are here in United States. Now who are the teachers back in the camp are all just high school graduate students. And that is how the education status came down. And lately we are receiving refugee population saying that they are high school grad, but they don't literally speak English.
Yeah, so some of the factors that could potentially be traumatic, not to say that they necessarily are, but they could potentially lead to traumatic experiences, are limited English language skills, lack of employability skills, especially for seniors, so an inability or an unwillingness to work, having difficulty with transportation, getting a license, having a car, and misunderstandings or fear about bills and utilities, how to pay that, what it means if you don't pay, how important it is to pay on time, and then misunderstandings about benefits, social benefits, welfare benefits like food stamps, cash assistance, Medicaid, how those all work. It's confusing for us to understand without language barrier, so it's a whole other barrier to consider. Some of the major health concerns that we see are chronic conditions, and often medical treatment that was in the camps was very basic and no kind of preventative care. So the idea of going to a regular checkup with your doctor, even if nothing is wrong, might be completely foreign. Hypertension, diabetes, those kinds of chronic diseases. Alcohol use and depression and suicide, Michael talked a bit, but there was a CDC report done in 2011 looking into the high rates of suicide in the Bhutanese community, Nepali community especially. They're much higher than in other resettled refugee communities. And then again, confusion about specialists, referrals, wait times, how it works to get into a certain provider, and how to express your concerns once you're there. Okay, so just quickly, a bit about what Chris is doing to respond to these issues. So we are doing mental health screening around 30 days after arrival at the cultural orientation that Juma mentioned, with using a screening tool developed by a team called Pathways to Wellness. And it's a 15 questions screening instrument. It's predictive, not diagnostic, of PTSD, anxiety, and depression in newly arrived refugee populations. And based on those scores, we would follow up with a home visit usually and see, we don't use the term mental health because of stigma, but ask, what are your needs? What ways can we help to support you? And then do strengths-based case management from there to connect people to the resources that they might be needing. We don't have clinical services at CRIS in-house, so we're always reaching out to providers and referring to whatever sources that we know are best at meeting the needs of our clients in culturally and linguistically competent ways. We do also community adjustment support groups, so that's a curriculum developed by the same team that developed the screening instrument we use. And they're 8-week sessions to basically offer support. Again, we're not specifically talking about mental health, but it's about kind of creating a space where people feel comfortable and open to sharing whatever is going on for them. We're doing kind of alternative wellness activities. So we find that for the most part, people are not comfortable with a Western model of therapy or seeing clinicians or counselors. So rather than force them into that mold, we're offering alternative activities, including yoga, kind of therapeutic music, to access those emotions and create a space where, again, people feel comfortable and supported to share whatever is going on. Youth activities, Juma mentioned, to target some of the high dropout rates, some of the lack of engagement that we might see in the youth population. Health courses to explain about preventative medicine, about preventative health, and things we can do to stay healthy, especially with aging. And then suicide prevention. This is really trying to address this issue head on and not avoid it in the community. So we've done a few trainings in partnership with OSU to create a dialogue and talk about ways to support change in addressing the issue. So I know we covered a lot, but I just included some resources. I don't know if these slides, you have access to them if you're emailed them out, but these links have a lot of different information about just mostly background information on the Bhutanese Nepali community and some health trends that you can see. So if you're interested in learning more, feel free to check those out. And then we have our contact info as well. If you have specific cases, I don't know if some of you are clinicians, but if you are in Columbus and you have specific cases that you are struggling with or need some direction, we can always serve as a point person for that.
And so I want to open up the floor for questions from our satellite sites or our hospitals and also here.
Because you said when the Bhutanese Nepali started to be resettled in the U.S., there was kind of a dropout of studying the Bhutanese content in school. So did you find, or did people start to study English more because they thought, or they knew there was a possibility of being resettled in an English-speaking country?
Kind of just the reverse actually. People started dropping from the school. The reason is that they would, most of them would feel that, well, this tone of English, this accent of English is not going to work in the United States. So if I struggle hard to get through this here, I'm not going to make any use of this back in the United States. So I have to go and study there, or like there will be no way out for me. So that is how many people they just put themselves bar in education. And even like there were some situations where students, parents were more dominated by their children, saying that, well, I'm not going to this school because you agreed to go to United States where I'm not interested. So it was a kind of mistrust, and that is how it's generated. And there were a large number of dropouts when this resettlement process started, because I was a teacher in the camp at that time in 2008. So I know there, in most cases, we went back to the camp, visiting families, why the kids is being dropped, and they say he's not interested because I applied for third country resettlement, and he doesn't want to go. And so, but now, and those students, when they are coming here, now they are realizing there was a big gap of misunderstanding.
So my question is to the panelists, what are some of the greatest, what would you say, one or two of the greatest barriers for the populations that you're serving right now to them seeking help to receive behavioral health services or health services in general?
I think the greatest challenge is that we have wonderful behavioral health systems in our respective communities across the state. The challenge is that we're kind of at very different levels of sophistication and fully understanding what is it to deliver culturally competent behavioral health treatment and care. And examples are Cayuga County and Summit County. This Bhutanese suicide issue has become a very serious concern, and the system isn't fully integrated and comprehensive at this point. And part of that is that, in terms of delivering treatment, like therapeutic care through therapists and counselors and so forth, the potential people that can deliver this care has to come from the community itself. And if the refugee community, for example, and the Bhutanese Nepali community have just only recently arrived in the last several years, that's the pull that you're pulling from to try to train, get them in a place where they can deliver treatment care to their communities. And it's a challenge because among the pool of refugees that are there who are English proficient, who have background in mental health services, it's very limited.
Yes.
And so, what is and this is a nagging question I think we're all struggling with, and I don't think there's an easy answer to it, is that what is the other alternative viable solution? And I think that's a big struggle for us all right now.
Yeah, I would definitely agree. And we have gone into communities and seen a need and people requesting services, and then we aren't able to meet that with culturally competent services. And that is such a hard position to be in, because it's different if the community isn't reaching out, if the connections aren't being made, but the options are there. That's a different approach we need to take. But when really the resources are not there in a way that meets the community's needs, it's really a challenge. So we have also been exploring different options in partnership with behavioral health organizations here to develop Nepali programming, to partner potentially with Columbus State to kind of allocate some scholarship funds to help bring up paraprofessionals from within their communities in the health professions. So different ways that we can kind of address the issue, but we are definitely not there yet.
And the other reason is also the camp background of the Bhutanese Nepali community, where they came from. The refugee camp never had that opportunity for these refugees to go to obtain that greater education, like especially in health sectors, becoming a doctors, or like you may find 5 doctors among these 75,000 refugees resettled in the United States, 5 doctors just. And like, so to going to get that education to that point was it was beyond the dream of like general population, refugee population there. That is why we don't have any skilled refugee population in the community who can help. And the other factor is, I think Michael brought it, is a stigma factor. People, suppose if I have a mental health problem, like mental health issues, I would never disclose that to my family members. Neither I disclose to Sarah when she comes and interviews me or my family. Because if I tell her that I have, or my mom has a problem with that, then they kind of feel a kind of mistrust. Well, she might go and speak with my neighbor, and tomorrow I'll be out of society. So that is one factor that is most, in a greater percentage prevailing in the community, where people, they don't get themselves exposed out. We are trying with different processes, like through music, through dances, through yoga, so that people will slowly come to us and talk to us. Sometimes having a Nepali speaker with Sarah going and visiting the families, so they might speak up and we might be able to connect them to the service providers. And it's really very hard to get. The one thing is they are very new to the country still. It might take, but that would be too late for taking care of those. So really these are very alarming issues. Suicide is another one. Like you may come across a person today and tomorrow you'll hear, well, that person has committed suicide. And these people would never come and explore. They have a lot many social issues, like as Michael also brought the same thing, like usually with the employment and like with benefits and everything. They cannot express themselves to their family members. Maybe if my father has a problem like that, he would not tell that to me, because he will feel that he is the most responsible person of the family as a head of the household. So if he's going to tell that to me, he's not doing his job properly, though he has a language barrier. So then he will feel so much saturated with that. Oh, I came with the hope to help my families, but I'm not able to do that. So that might like bend his way towards thinking about suicide and eventually ending up doing that.
If I may add or echo to the panelists, I am a former refugee from Southeast Asia, and also I help settle former refugees from Southeast Asia. I'd like to stamp approve what they're saying. It's very difficult to get patients or refugees or clients, whoever that you will call, to come out of their community comfortably. They are withdrawn, they are, what else I can describe? In a mental health form, I know that they are totally isolated to themselves and within the community. They're not comfortable to go outside of the community and share their problems. In the long run, there are refugees that become mental health illness without they realizing it, because they start with depression, withdrawn, isolated, and then they become, later on they become having anxiety attack, those things that they don't even know. until a professional that say, okay, you are really depressed and you need to take the medicine. But they're not going to admit that they have mental illness. And they do not want to come out from their comfort zone. Another word. I want to go back to what Michael said. Only way that you can help the community is to find one of their own from the respected community. Maybe feeding the pipeline from now. How are we going to help them to work out on these problems? You talk about the school dropout. That's very typical. Kids that came, I can give you an example. Children that came into United States during 1980s, 90s, if they are in a high school, they cannot fit in. One, they did not speak English at the time. They cannot pursue academically in high school successfully. They don't fit with the peers. And at the time, kids in high school also did not know anything about other cultures. And they get bullied, they get looked at, down upon, and then they quit. They rather go to work at the restaurant. I can name those folks today that still working in the factory, worked at the restaurant, feeding themselves and their family. I mean, it's not bad that they are working at the restaurant or in the factory. But because they came in young age like that, they should have been or could have been one of the persons that can be in helping others that cannot help themselves or have zero background education at all. When older folks that came in at the time, and same way with Bhutanese came in right now, if they have zero background in education, and for most of the Southeast Asians came to the United States here, at least here in Ohio, during 1980s and 90s. Majority of them have never been in school. If they did, maybe like first, second, or third grade. Especially women did not get to go to school. At the time when they came in, they were like farmers and working in the like homemakers. So that's my 2 cents.
Okay, we have just a few more minutes. I know Dr. Belaswamy may have a few comments.
Yeah, I want to just reflect back on what Michael and Juma mentioned, that I think it's not only lack of transportation or interpretation services, but where mental health is concerned, we actually lack culturally competent therapists. There are very few and far in between. We definitely have abundance of psychiatrists with Asian background, but they are not really providing counseling services. So there is a big gap in the field right now of culturally competent therapists and counselors, which could be a challenge for both the communities, the API community, and including Bhutanese and Nepali, and I'm going to talk about the South Asian community. So I'm kind of getting anxious about the fact that everybody on this panel who are delivering services to the Asian Pacific Islanders seem to be resonating these three major issues. Service for interpretation, which is also lacking in the community, transportation services, because refugees and new immigrants don't drive, don't possess cars, are unable to negotiate the system. And also the third thing that kind of, you will hear me say this again to you to reinforce the idea that mental health is a highly stigmatized in these communities. They do not speak about it, they do not share about it, and great reluctance to access services. And I'm very impressed with the two of the speakers who said they had created some new venues for recruiting and people to work with them for providing some assistance. I think in my presentation you will hear with, we are thinking about starting informal support groups and creating venues for where we can have peer counselors, because we can't tell OSU, for example, recruit a lot of Asian students and train them as social workers with license to practice in the community. That's way far down, in the future. So in absence of that, I think we have to get creative in how we provide services, behavioral health services to API groups.
Next, I'd like to introduce Boomtan Pamaset.
Good morning, everybody.
Good morning.
Good. I am, I'm gonna tell you the story instead of presentation. How's that? I think that everybody, all the panels have presented you about direct services that the Asian or the Pacific Islander have provided. And you know about the Asians overall, the needs and the directions that you need to help us to get through, maneuvering all these systems. But I would like to go to upstream instead of direct services for today. I know that you probably do not have heard of Ohio Asian American Pacific Islander Advisory Council. This council is served as a pleasure of the governor. And before I go on, I'd like to recognize the member of the council. Michael Bian is one of the members that help to organize this council. And he's the backbone of this council for years. The Ohio Asian American Pacific Islander Advisory Council was initiated by the previous governor, Governor Strickland, in 2007. I don't know if you heard of Dr. Liu. Dr. Liu is shaker and mover that helped to organize the Asian Festival. He's the founder of the Asian Festival here in Columbus, Ohio. So he is also the mover and still the shaker of getting this council up and running. Will we be successful? We don't know. But what we have now is that an executive order that provided or honored by the Governor Kasich as is right now. We have an office on the 18th floor on 77 South High Street, which is Vern Wright Building. All the employees are non-paid. We are volunteer staff working for free. And our goal, our dreams was to have an Ohio Asian American Pacific Islander commission. And that's what our dreams is. So, make a long story short, let us move on to the next slides. You have my slides that start with the Ohio Asian American Pacific Islander. Okay. As you can see, how the composition of the U.S. society is changing rapidly with the AAPI, which is, I will call AAPI as a short or acronym from Asian American Pacific Islander, AAPI. As you can see how the percentage has been increased and add on to the U.S. population. And I know that you know yourself, and you know that you can explore yourself how important that we need to work together. Okay. If you ask me, Asians been here for a while, and especially the Southeast Asians, the Chinese, the Korean, the Japanese, so on and so forth. What have you done so far? You probably asked us that. What have you done? As a leaders, I mentioned Dr. Liu and Michael Bian and other people that in the advisory council together. Our governor, Kasich, honored us with an executive order 2011-09K. I just want to point out some of what he wished or what he want us to work on the AAPI populations. He said, this council should reach out to AAPIs on the Ohio, and especially for the policy decision makers bodies. He said, improve access to state program services that you have. How can we plug in our folks to different programs that you have? And that's what he meant. Encourage culturally relevant education, faith, and arts. He said, do that. For economic development, he said, why not increase awareness of MBEs, which is Minority Business Enterprise, and EDGE. Develop community health education, screenings, and provide education to the old, the youngs, and everybody, the AAPI, on chronic diseases, and provide them with the available treatment plans. That's what he said. Okay. And this is just some of what he said. I will not read the whole thing, the whole executive order. Increase awareness on Asian Heritage Month, he said. Those are just some that I chose out. So, the council gets that. We know that we have to do something in the upstream because we want to compare ourselves to the old comers like the Hispanic Commission Affair. They exist. They start with one executive director and one secretary. They exist until today. Ohio Commission on Minority Health, for example. So we want to be up there with them somewhere to work with our AAPI population, at least. That's our dream. Okay. All right, so the committees the members of the AAPI council that would provide advisory to the governor, saying that, okay, we have 4 standing committees and 4 charges to cover all those executive orders. 1, arts, culture, and education. 2, civil rights and immigration impact. 3, economic workforce development. 4, health issues and healthcare system. These are broad areas that we are charged to do, that we owe to governor, that we owe to AAPI populations. That's how we feel. All right. So since these are the charges that we have to do with no resource, with nothing. We are not even AAPI commission. We are only a council operate under executive order of the governor. Okay. What have we done in terms of arts and culture education? I could just briefly put it out there for you. And Michael, you please jump in anytime. Okay. We do have established Asian Festival, especially the one here in Columbus. I don't know if you've been to Asian Festival here in Columbus, Franklin Park, that we conduct every single year on the weekend of Memorial Day. For this year, for 2015, will be 21st year. So, what do we do there? The Asian Festival have been expanded out to Cleveland, Cincinnati, and Dayton. And in terms of arts and council, since day one that we did Asian Festival, we asked of Ohio Art Council to provide us some funding so that we can bring the artists or maybe or many of the community grown arts to display cultural dance and the art forms that they can perform at the Asian Festival. What are little small funds? Okay. In terms of education, in Ohio, there are 7 immersion schools, and the newest school and called Global Ambassadors Language Academy, and with acronym GALA. It is a tuition fee from K to 8, and right now they have it in August. They will open one in Cleveland. It is a language immersion school that will offer both Mandarin, Chinese, and Spanish immersion options that international baccalaureate primary years program. Okay. Because of the Chinese, the Korean, the Japanese, they are more affluent communities than the Southeast Asians. They can do this, they have the resource. But it's not that they do not need the services, they do too. I want to point out some Southeast Asians that are former refugees from Laos, Vietnam, and Cambodia. What we do here in Ohio, we rely so much on monks, Buddhist monks, the temple, because we have no centers to go to. So Buddhist monks, the temple, Buddhist temples are the solely place that many people would come to, for getting help. Community leaders like us would go to the temple, and when they come to the worship area, and it's not only just worship, it's called community center for them, so they can come in and share their problems with their peers. They can share problems with the community leaders, the shaman, and also the monks. So we found that it's the best place that people can come and help themselves and be able to meet with their peers. So that's in a nutshell. Let us move on to the next slide. How I'm doing with the time? Okay. Now the next committee, Civil Rights and Immigration Impact. Michael Bian, Dr. Katsuyama are the committees that's steering this committee. This one is very large and very complicated, as Dr. Katsuyama said. But what have we done under this Civil Rights Immigration Impact? Dr. Katsuyama and the members of the council, like Michael Bian. Members of the council serve on the planning committee and help promote protecting civil rights, town hall meetings, and other meetings that would help to know your rights and responsibilities as AAPI. Dr. Katsuyama said the topics that he was attended in several meetings topic included hate crimes, law enforcement, community relations, a deferred action, childhood arrivals, which is called DACC. The panels consisting of diverse group of students, discuss problems and accessing services for which there are hopefully and should be, and I'm not sure about eligibility of this, such as state tuition fees and driver licenses. And I know they are working on it, right, about licenses. But about the state tuition fees, I'm not sure, because I know international students pay 3 times than Ohio student pays. And international students make up income to Ohio and throughout the nation because they came to study in the United States, and they pay that much tuition, 3 times of a regular student in Ohio or somewhere else would pay. So, the next and the last but not least, the third one, the third charge is economic workforce development. What else have you done as a community leader and the council? What else the council done? The council has promoted education about minority business. If the restaurant owner, minority business, or the AAPI businesses would like to be on MBE, and EDGE, which is the encouraging diversity, growth, and equity with the state of Ohio. When we did the presentation, we shared them the information. They said the red tapes And democracy is just too big, too large for them to handle. The paperwork that needs to be turned in, it's about a box to get MBE and Edge. Maybe at least £6. And I have done it myself too. That much. Very difficult to get in the system. And they said, forget it. Forget it. As well as applying for money. As much as the system say, you are a minority business, you serve in minority, and you are a minority-owned business, you can apply for SBA funds and all that. That's not true. I tried it. Didn't work. None out there. So they said they're frustrated. Forget it. And that's why they ended up borrowing the cash advance. Do you know what that is? Cash advance, business cash advance. If you borrow $100,000, you pay back $190,000. If you watch Shark Tank Nation, that is just exactly like that. And I watched one last night. A couple want to start up a family business, restaurant. And the Shark Tank said, I will give you $200,000, but you have to give me 50% of your ownership, of the restaurant ownership. On top of that, you pay me back $400,000. This is true. You can go back to look at the Shark Tank, what it said. And the couple said, no thank you. That is the true story. And same way that I thought about the AAPI economic development. All right, I talked too much. Let us move on. Let us move on. Now, last but not least, health issues and healthcare system. This is the big issues, big one. What else we have done since governor said, you do this and this is your charge? We have been working promoting access to health programs and services. You know, we tried at the mental health board, and I know that Michael can tell you the story all day long, that how he plugged in AAPI into Adam Board and been working with Adam Board. Dr. Liu, I mentioned earlier, was the mover and the shaker. He's also a president and chair of the Asian Free Clinics at Ohio State, at the Ohio State area, and helped and funded by Ohio State Wexner Medical Center, Wanda Dillon. Dr. Liu also organized meal program for senior citizens. So, but that is just for one community, the Chinese community. How can we deliver to all AAPI? And that's what the council is working on. But we can't do anything when we have no money, and we can't do anything when the governor did not fully support to have AAPI commission. Okay. You know, we have health screenings. We screen more than 500 screenings, serve more than 500 to 600 people at the Asian Festival Health Pavilion every single year, that funded by the Ohio Commission on Minority Health. Many of the Asians, that was the only resource, the place that they look for to get screens, especially the seniors. They came to live with their children because the children are physicians or educators, or they came in later in years that they would not, if they become or if they receive green card or permanent alien residence, that's only the source that they would be getting health screenings from, because they're not going to be eligible for medical cards per se or in other insurance. CDC funded the Ohio Asian American Health Coalition to do hepatitis B. Okay. Oh, I talk about senior health program. There's other things that Michael and Dr. Cora Munoz, I don't know if you met her, participated in national network to eliminate disparities in behavioral health with they call the NNED Learn program. We try many ways, many things, anything that would help to set the system up there to assist the AAPI in the long run. And our hope is to get these 4 charges fully implemented by working with you, the state agencies, community organizations that we have, existing community right now, the resources that we have. And I know Michael Bian is our commissioner who represent us at the White House AAPI initiative. So we have tried our best to link our folks into different programs that you have. Without collaboration, without knowing or learning from you, we wouldn't know of you or what other programs that you have. So just show us the way. Sometimes you have to hold our hands. Okay. Bottom line, in a nutshell, the recommendations from the report, we owe Governor Kasich a report for 2014. Our dream is to become AAPI Commission. And we encourage many state agencies, not only Ohio Department of Jobs and Family Services, because they are providing us some small funding to have an office. And we have a broken Xerox machine there, cannot even use, and provided by Job and Family Services. We want to see more funding so that we would be able to work with our populations. And the small community organizations like this need more funding. Increase the funding. That I say that again. Increase the funding to community and faith-based organizations where the respected community can get services with your help. with your guidance. And other recommendations from the report is that train CHARs, which is community health advocate, like these folks that we're working, sitting here in front of you, to assist Ohio API for the above charges, for all these 4 charges, so that we can help to feed the pipeline of the vulnerable populations that who are in front of you. I thank you.
Our next presenter is Christine Yelpin.
Hello, my name is Christina. I'm from Cincinnati, Ohio. I just give a little bit about myself real quick. I have been working with a couple of youth programs in Columbus, Youth Move Ohio, Youth Empowerment Program. I'm a youth advocate. I bring the youth voice to the table, where our youth voice is not heard, where youth voice is rarely heard. On panels, councils, we just bring the youth voice to the table, because it seems like our voice is ignored by so many programs out there. I am 25 years old. I am an Indonesian American. My mom was born in Indonesia and immigrated here to the U.S. when she was 6 years old. My dad was born here also in the U.S. Main issues I faced being Indonesian American was when I was in school, that I would be bullied, I would be made fun of for being Asian. But and it would make it hard to concentrate in classes, because people would always constantly make fun, say Chinese, Japanese saying, I forget the saying these days, but when I was born with fetal alcohol syndrome to a mom that was also mentally disabled, so our mental disabilities would conflict quite often. My dad was an alcoholic. He would be very abusive to my mother. He would be putting her down a lot. In his later years, that slowed down quite a bit. I guess I was born with challenges from the beginning. When I was born with fetal alcohol syndrome, those people born with fetal alcohol syndrome only have like a 30% chance of survival. Thankfully, my family was very supportive on both sides of the aisle. The Asian side of my family and the American side of my family, which from my understanding is very rare, and very thankful, and I'm very grateful for that, because I was talking to a family member of mine that lives in Indonesia right now, and she said that over there they don't have that support. That that unless you are born into wealth, they alienate you, because because being mentally ill over in Asia takes a lot more money, because the schools are very expensive, the health care is very expensive. So you never really realize how well you have it over here until you talk to somebody over in Asia, over in Europe, because it's completely different over there from my understanding. They have special, as I said, they have special schools over there for the mentally ill. Throughout my life, I have beaten many odds, and I think that is mainly due to my family support. My aunt, my uncle have been my major line of support. Thankfully, my mom has had a lot of support also, so it made her made her person she is today, and then helped her make me the person I am today. When I was 10 years old, I entered foster care. I went from foster home to foster home, probably 7 different foster homes. Due to my acting out, I was constantly acting out because nobody knew how to handle my diagnosis. I wasn't properly diagnosed until I was 17 with my mental illness. People always thought I just had ADHD, so they just thought. So it was never. My diagnosis was never fully treated properly until I turned 17. When, in that case, till I was almost an adult, so it was harder to find me treatment. When I was in foster care, I was placed on several different medications. Some helped me more than hurt me. Sometimes I felt like I was a test rat, I guess that's what I was saying. I felt like no one ever listened. And when they did, they didn't understand what I was telling them. When I was in foster care, I was abused by my foster dad. I told somebody about it. Nothing was ever done. So it's like that's just one instance of many where people never really listened or did anything about it. Major challenges I faced was not being able to find my voice, not knowing how to make my voice heard. And when it was heard, having people understand my voice. Thankfully, through the programs I found later in life, in my youth, young adult age, I found my voice to help others who have faced the troubles that I have faced in life, help them to get through similar challenges that I've faced, so that they could have a better life, so that those that don't have a voice have a voice through me by telling my story, so that the people that are supposed to be helping them will learn how to better serve those youth. When I turned 14, I was placed in family care with my dad and my stepmother. That's when I finally realized people were listening to me a little bit later on. My stepmother was very, trying to think of the word, sorry. She would always be putting me down, never care about never could find any right in me. And then I came up here to live in Ohio came up here to visit my aunt here in Ohio. And that's where I finally found somebody that listened, that understood me. And that's where I was finally properly diagnosed. My aunt took me in under her care when she realized my stepmother was always putting me down, very mentally abusive to me. When my aunt took me in, she got me the care I needed. She took me to Cincinnati Children's Hospital where I was properly diagnosed, and they could figure out what was wrong with me, figure out how to handle my situation. And I think that's by coming up here to live in Ohio, that is what made me who I am today. Because if I had not came up here to Ohio, I wouldn't have had the opportunities that I've had this day and age. Since then, I've become a better person. I have volunteered on many boards. I have gotten a job, which is I graduated high school, which people with mental illness really do not graduate high school. I forget what the statistics were. People coming out of foster care, there's 40% of those in homeless shelters are at one point or another were in foster care / family care, from my understanding, or had some interaction with the juvenile justice system and everything else. And so I'm glad I beat the odds. Sorry, I'm drawing a blank right now. Okay. But thanks to that, I'm now 25-year-old that has a job, that has graduated high school, that has made a difference, I believe, in the community. I read a statistic online the other day, and some of these people on the board, on the panel here, said Asian Americans, 20 to 24 years old, we are the highest statistic to commit suicide in ethnic race. 20 to 25 or 24 or 25, I can't remember the exact year. So just odd after odd after odd I've beaten, and I'm proud to say that I've beaten those odds. I volunteered on the Romney campaign. And I've met very many people through that. I met the governor several times. I've met senators and congressmen. Through that, it's like I know my voice is being heard at the highest levels. And I thank you for that. Any questions? I guess at this point.
I have a really basic question. Where did you live before you moved to Ohio?
Texas. Dallas, Texas. That's where parts of my family live at currently. Any other questions?
Do you think, like some of the other panel members have talked about the need for folks, young people, in your community to go on and get more education so they can be reaching out maybe as a counselor, social worker, or something? Do you have any interest in doing that?
Right now, it's like I'm planning on possibly going to college. Right now, it's a little bit more challenging, but I hear what people are saying is like, from our generation, dropout rates are crazy or ridiculous. I don't know what the specific statistics are when race to race, but
I just think you have so much talent that.
But I think people just. I think there needs to be more help out there, because for financial aid, I think that's the main reason. Because when people are, my boyfriend actually told me something. When people are coming out of foster care, they go into the military because they are told that's their best option. I think there needs to be more options, because there are people out there that don't. I mean, they want to, but they're afraid to go fight for our country. Because would you want to risk your life dying? But after the age of 21, there's very little help out there for young adults that want to go to college. That's the main issue I'm facing right now, because a lot of scholarships that are out there are mainly for youth that are in high school, that are just barely graduated high school up to the age of 21. So that's where the issue I face, because who wants to take a loan and have to pay that back if they don't have to? Because some people can't afford to pay those loans back.
Well, I wish you luck in getting that help, because I think you do a wonderful job.
Any other questions?
I will say, go ahead and ask now.
Christina, you said that first of all, thank you for sharing your awesomeness with us. Thank you so much. You talked about not being heard, your voice not being heard, and you talked about how you felt when you were taking different medications. How did you get your voice to be heard when it came to the medications, so you wouldn't feel like you're being...
My voice really wasn't heard until I went to live with my aunt and uncle. They took me off the medications because they realized just how much it was hurting me. And when I was taking off the medications, I still have issues, but my issues are minimal in comparison to when I was on the medication. My disability really doesn't affect me very much. It affects my attention span a little bit. It affects my decision-making skills a little bit. But that's about it. And I think those are issues that everybody faces in life.
I have that.
So it's like, to me, I act out every so often, but rarely now. I think it's just, when I found my voice, I found a way to take out my frustration, take out my anger without acting out.
Our last presenter is Dr. Shanta Belaswamy.
So I heard my co-speakers actually talk about themselves, so I'll be remiss if I didn't do so, right? So I'll tell you, I've lived in this country for 34 years, came here as a young woman, starting on a journey with a fellowship for learning about children's services in US, and came here on a Fulbright scholarship that seems like neons ago. But my work trajectory has changed over this last 30-some years. I got my master's degree in social work, PhD in social work, but got my postdoc fellowship in gerontology and aging, in the field of aging. So all at Case Western Reserve University, and I'm a big fan of Cleveland. I do like Columbus. I've been here as a faculty for 17 years at OSU. So that's kind of in a nutshell. But Jamoya also gave you a little bit of my research interest. I want to tell you why I look at my experience at Asha Ray of Hope, both as a president and also as the chair of the direct services, doing direct practices with domestic violence survivors. Looking at it from a lifespan perspective, I've taught courses on women and aging from international perspective, and I never thought that it'll come to use till I got on the board. But I want to give you a short, brief introduction to the organization that I'm representing here today. Asha Ray of Hope has been in existence for 11 years. It had its humble beginnings with few women who were interested in helping South Asian women to overcome difficulties of finding housing and trying to leave their marriage. So those were the humble beginnings with Dr. Raja, who was the pioneer in starting this movement in Columbus, Ohio. She's has passed away since then, and our organization has actually became a nonprofit status only in 2003. So since then, I have been on the board and have worked with Asha. And I'm always amazed at Asha's ability to provide services using exclusively volunteers. You can't imagine in this day and age to have a number of women, both professionals and homemakers, who all have congregated for the cause of helping domestic violence survivors in the South Asian community. So I'm really proud to be on it, but I don't think my family really is happy about it, because you know, when an organization is run by volunteers, it means a lot of work. So I am making like ends meet on both sides, being a full-time work volunteer at Asha Ray of Hope and being a faculty member with all the obligations which pays my daily bread. So it has been a challenge, but I'm amazed at all of the women that have sought with us to help women. So what can I tell you? Overall, I want to kind of give you this much information, but I'm going to integrate throughout my presentation how Asha serves the domestic violence survivors. Our mission statement basically is to assist, support, and help and advocate for South Asian women domestic violence survivors to make a transition from being a victim to being a survivor, living a life free of violence. That's our kind of, in a nutshell, our mission statement. And I think we are upholding that pretty much to the T. So my presentation, I'm going to give you a quick overview of prevalence of domestic violence in the South Asian community. I'm going to discuss barriers and risk factors that hinder delivering services to this specific group. I will integrate both scholarly work and my personal experience as a direct practice worker for Asha Ray of Hope in providing that information. Towards the end, I'm going to try to share with you some best practices that will help service providers in the community, regardless of whether you're a mental health service provider, whether you're a health service provider, or you're a social service provider, to learn a little bit about cultural competency when working with the South Asian population. So why should we be concerned? Why are you all here? Why did Jamoya ask us to talk about the South Asian community? You already heard from the previous panel members about the statistics, the growing number of South Asian community, in South Asian population in our communities. So the one demographic about South Asian comes from the 2010 census data, which you have in front of you. You know, there are about approximately 3.1 million multi-race, multi-ethnic, and single-group Asian Indians. We also have 147,300 Bangladeshis, 409,163 Pakistanis, and we have very little knowledge about percentage of people who are Nepali, Sri Lanka, and Bhutan, which is unknown. Neither do we have statistics statewide, nor do we have locally, nor do we have nationally complete statistics. And the reason I cited all these groups are because these groups are considered as South Asians. People from Bangladesh, India, Pakistan, Sri Lanka, Bhutan, and Nepal. And those are the communities that we serve at Asha Ray of Hope. In Ohio, we have just have percentages. We know that 2.1% of our population is Asians. You know, Asians include South Asians too. So I couldn't find any data actually to separate them. But what's very interesting is that since 2000, we have 49% growth in this South Asian or Asian population in Ohio. So, you know, they're all going to be at your doorstep at some point or the other, whether you're an EAP person or, right, did I say that? And all of you who are working in various fields, you're all going to come across this group of individuals as service providers. Also, you may want to ask, why should we be bothered about language? What has language got to do with anything with service providers? Here is some hint for you. So if you look at the 2010 census data and the 2006 to the American Community Survey, which provides estimates, you have to at least know that when we talk about South Asians, they come from various background where language is concerned. It's not a common, unique language like the English language that everybody speaks, right? So when we talk about the immigrants or when we talk about refugees, they both have language as a big barrier to accessing services. So I thought it was appropriate to share with you. So we know that, you know, of those people who speak Gujarati, which is quite the second highest language spoken by South Asians, at least 31.1% of them said in the survey they cannot speak English that well. So that's 35%. Then you have the Hindi speakers, which is the majority of them in the South Asian community. We know that while most of them tend, at least, 79% say they can speak English pretty well, you still have to deal with the 21% of the population that doesn't speak the English very well. Urdu is the third largest language spoken among South Asians, and in that group, at least 30% of them speak English less than very well. What we have faced at Asha Ray of Hope is that those are not only the 3 languages that our client population speaks. The other languages that we have to address are Tamil, Telugu, Malayalam, Bengali, Marathi, Punjabi, Nepali, and Bhutanese. Can you imagine? Just think about all the interpreters that you may need when they go knock on the doors of the court for getting legal services, and the court decides that you have to be certified by the court in order to be an interpreter, and we are working in the field of domestic violence. In fact, of the 47 clients that we currently have at Asha Ray of Hope, all of these languages are spoken by them. And we do have a good cadre of volunteers that we, over the years, have accumulated and requested people to come on board to help us do the interpretation. So we already, I think, my co-presenters have identified language as a barrier, which means the service that we most need in the community would be interpreters. Chrissy does it, but they have very few. They have only 2 interpreters speaking Nepali. And we have to depend on, and there's a growing number of Nepalis in our community. When we call them, we have to give them 24 hours or 48 hours before they can. The court has the prerogative to have them before the healthcare providers will have the prerogative to have them come for the services. So it's definitely an issue that shouldn't be underestimated. Something of interest to you as we talk about the demographics. Asha serves both men and women who are victims of domestic violence, not just women alone. And we want to make that as an, openly have a discussion so that people understand that we are not very feminist-oriented organization where we believe that intimate partner violence occurs only between what's the word am I looking for? Heterosexuals. Thank you. Are you all paying attention? Okay, good. Okay, so in the last 4 years, I can tell you we have had about 5 male clients, and the rest of them were all female clients. So definitely we think that our job revolves around helping South Asian women rather than men, but we do have reached out for men too. So what do we do in order to be proactive in terms of representation? On our board, we have men who are our board members. So they do represent. As I told you, you should always remember that we are a volunteer organization, which means we tap into, and the board is a working board. So I'm the president, but I'm the working member of the organization. So the board members actually pitch in, and we have 9 board members, and 4 of the board members are men. And they help us with all kinds of, that's a strategy that we have adopted so that we can raise money, we can do a lot of hard things that we need to do. A good example would be when we want to move a survivor of domestic violence transitioning into the community, and we need to give them resources from furniture to everything else. We have our men help us carry all of those requirements. Material stuff, anything heavy lifting is all men. When we have our fundraising events, when we need organizations to organize these events and to pull together certain things, we depend on them. Also, the most important thing I want to share with you is men have become the spokesperson in our communities. They are out there talking to the other men about prevention before a situation escalates. They also talk in temples, in gurudwaras, in the mosques. They will go and talk to other men about importance of treating that woman right. And also talking about services, access to services. So they have been the immense amount of support for Asha Ray of Hope. Many of our women, if you read the mainstream literature on domestic violence, it talks about the amount of time that it takes for a woman to leave the perpetrator, and number of times that they return to the perpetrator, even though they made a decision to leave them, is about 4 times. Minimum on average 4 times they make an attempt for reconciliation in the mainstream. In the South Asian community, it's a prolonged period of engagement before they will leave their home. And that ranges considerably. If my memory doesn't fail, and if I can find the notes, I'm going to tell you, it used to take about anywhere between 2 to 4 years to engage a client from the time they call with a complaint about being abused to the time they make the transition to going into a shelter. It's a prolonged engagement period. There was a study done by Dr. Dasgupta which showed that it took 8 years. In the 1980s, it took 8 years for women to make that decision to leave. And the reasons are many, specifically related to children. They will not leave the children since they are old enough to take care of themselves, which is age 15 to 18, or they would be high school graduates, and maybe they tolerate violence considerably in the meantime. Now, in the past 3 years, we have noticed a change in the trend of this quick decision making. So now we are looking at women who are more willing to make those choices and decisions of safety for themselves to transition into the community and leave their perpetrator. The range is between 6 months to a year. And the reason I'm going to tell you is because we are doing a fantastic job. I think we are able to harness the resources that they need in order to, and quick response to their calls, to develop a good care plan for them, safety plan, and also our coordination with the mainstream organization like ODVN, Sarenco, Choices. They have become a really good ally for us. We have really networked intensely with this group in order to get us the services that we need. We also, on the side, educate them about the cultural competencies that they need in order to serve our clients. A good example would be if we have our clients who are eat ethnically specific food, and they follow certain religious rituals, we help educate Choices caseworkers what those needs will be and how they can meet those needs. We also take our advocates to another level of pairing them off with our clients so that they can follow them and be informal peer counselors and advisors for them. And they drop off everything they need, take them to the temple, take them where they need to go. So the last few months, our volunteers, and including me, have been busy providing transportation, and more transportation services. So going back to before I talk about the prevalence of domestic violence, I want to also share with you that while we serve all those 6 different countries, citizens of 6 different countries. They're all from different ancestry. You have to know they have different, but we all share a very common culture. Anything that this panel member had alluded to today applies to the South Asian community, whether it's mental health concerns, shying away from taking a step to having those discussions or accessing services, reluctance to report problems within the community, all those actually apply. So anybody knows what are the major religions of the South Asian community? Just name it off.
Hindu,
Hindus,
Buddhist,
Buddhists, Muslims,
Catholic,
Christians, second largest population, and Sikhs and Jains. You got it. You all passed the quiz today.
We are in professor's class actually.
Yeah. trying hard to engage. So religion plays a very critical role because somebody made an remark about, going to churches or leaders or health, was it my colleague here who mentioned that they also seek help from religious institutions. I want to just cue you in on cultural differences where domestic violence is concerned. We work with Noor Islamic Family Services. We also work with Noor Islamic Mosque, and we work with Middle Eastern population, even though that's not part of our agenda or part of our mission. But we do provide a helpline where people call and we will refer them to various services. But one thing we have shied away from and do not do is refer our victims back to the community to get guidance or counseling from religious organizations. And there are profound reasons for not doing that. One of the main reasons is that within our cultural context, seeking advice and counseling from your elders or from your religious leaders puts additional stressors and pressure on a client to sustain themselves regardless of all the hardships that they are facing as a victim, to stay in that relationship. And we think that's a disservice for us to do that. So that has been one of our major challenges for having those conversations with the religious leaders and with the religious institutions and their associated organizations to say, we care about what you do for our clients, we want your resources, but we will not refer our clients back to an informal advising situation, informal counseling. They're good, but number one, we definitely give our clients choices for deciding whether or not they want to leave the perpetrator, but we give them options for how to do so. And that really where we have to have a greater conversation and discourse in the community about availability of resources. That's a barrier. If you cannot or do not offer them adequate number of services to support them to make that transition, they are more likely to retain their relationship because they are economically dependent on their perpetrator, which is not uncommon even for the mainstream community victims. So prevalence, what do we know about prevalence? There's a slide or on your handout that tells you about, can you imagine there is no national prevalence data, neither is there prevalence data here in the state, but there are like anecdotal stuff that's written about prevalence of domestic violence in the South Asian community. We also have this one study of 160 South Asians in the Boston area, and that speaks volumes and probably mimics some of our experiences in ASHA. There are about approximately 41 in this particular study, 41% of the participants reported having been physically abused or sexually abused by the current partners, and 37% reported having victimized in the past year. They asked those questions. And 65% of the women reported physical abuse, also reported sexual abuse, and almost a third of those reporting sexual abuse injuries requiring medical attention. If I had a lot of time, more than the 25 minutes, I would give you a lot of case studies. These are really a reality, and we have at least 3 clients who would fit in that particular category. And about 16% reported injury or the need for medical services as a result of partner violence. You know, what does happen is when a client calls their family member and shares this idea of that they are in a predicament because they have this intimate partner violence going on in their life, the first thing that they would be advised is to make it work. Make it work because you have children. Make it work because our religion says so, even though the religion is they misuse it and misinform the victim. Or they'll say, what will you do economically if you were to leave? Or there may be some issue regarding their green card. They're not a resident, they're not a green card holder, and they're, for their status, a legal status in this country is dependent. And you all know, those of you who are in the field would know that our laws are very stringent. You know, there's conditional green card, which requires the couple to stay in marriage for 2 years. So we currently have a client where we have controlled and taught her a lot of safety and issues and how to ward off confrontation with her spouse and how to negotiate and how to remain silent because she's only 3 months away from taking that conditional status from her record. So we are always worried. So that's a huge issue, even though the Violence Against Women's Act of 1996 allows for us to provide this extension of, getting out of this violence situation. It also requires to show good faith effort in the marriage and ample evidence to document that the abuse is occurring. So, for example, if somebody is constantly being emotionally or psychologically abused and or sexually abused, they will never talk about it. There will be no evidence to show that these two things are constantly occurring in somebody's life. So how do you provide evidence? The other aspect of this relationship has to do with inability to provide evidence is the fear of deportation. That they fear that they will be deported if their spouse is incarcerated because they press charges against them. Or they have children and they're afraid how that the community will stigmatize them or reflect on what the school area, where the children are involved in, how will they take the idea of separated parents? So divorcee and widow are highly stigmatized role status of women in South Asian culture. So how am I doing with time? So I did say there is no prevalence of data, but I can tell you what our data looks like. Our agency sees about 3 to 4 clients a month. You have to remember we have only a part-time office coordinator that we managed to get, train, and keep for the past 10 months. We have had this person, and previously also we had a person, but we ran out of money, so we do 2 major fundraising events that gives us the support needed for hiring somebody. So we are on a quest right now to do that again and raise money to sustain this, because in the past, before I took over as the president and the direct services chair in 2012, we had about, I would say, 15 clients a year. We have 47 clients only in 2014 alone, 47 clients. And it's really putting a pressure on all of us to work with. And we are also having a lot of calls. Our helpline actually receives calls from the mainstream, but we also get calls from the courts, from the hospital system, from mental health service providers, from health service providers, from all the social service organization, including the school, where this kid has reported about what's going on in their family, and the counselor calls us to see if we can intervene to see what we may be able to do. So we need more people. So our strategy was to get student interns from College of Social Work to come be intern with us and help them train as advocates. We required them to have 40 hours of training as an advocate for domestic violence. So that's our strategy. We have to make ends meet and somehow serve the client population that we said we will serve. So we are getting about every week or so we get 2 to 3 calls, definitely. We also get a lot of solicitation to help and to explore where they would go if they made a decision through our email address and web page. They can go in and send us emails, and there is always exploration. And I was reading a study by Dr. Das Gupta from Manavi, which is one of the largest organization for domestic violence survivors for South Asians in New Jersey. And they have a huge number of clients. So and they mentioned to me that the reason that you can have accelerated number of people that you may want to serve if you go and do a lot of outreach efforts. So our client population increase has to do with our massive outreach effort that we undertook in the last 2 years. We hold as a what we call chai chat. Everybody knows what chai is, right? Having tea and chatting over a cup of tea. And so we had these events, outreach events in all the religious institutions, associations, and we also put flyers about it in all the local grocery stores, etc. And they all help us to get clients who are thinking about it. And so that's our strategy for doing outreach effort. And that has really given us more than we can serve. But as I said, that we are doing our best what we can do. That's a challenge. Keep in mind, that's a challenge. I had lots of data, but I'm going to pass those over and put that. So I want to talk about quickly about cultural competency. You know, I was asked to talk today about some cultural competency stuff. So when we talk about cultural competency, I think we get all knotted up and think it's such a huge thing and we need to have a degree to order to serve our clients. So I want to give you some really basic definition of cultural competency. And today you heard our co-speakers, like my co-speakers all talked about issues that makes this API group, the American Pacific Islanders, which includes the South Asians, different actually. Because of linguistic differences, right? So Simply put, it's an understanding of someone's specific culture may require different approaches to care, whether that may be speaking their language, adapting to religious or cultural customs and preferences, or generally focusing on the individual needs and concerns. So you can see all the authors that I quoted who all agree with me on that definition. I think it's a collage of people's things. So, and what do we mean by culture? When we talk about culture, what do we mean? We sometimes misconstrue it as being race or ethnicity of the person, but that's not it. I think culture is comprised of a number of factors, including the family, social, economic circumstances, communication styles, value systems, and personal experiences, which may all impact an individual client or service provider's perception about it. You can fill in the blanks about. Here, for me, it's causes of domestic violence. It could be causes for suicide, causes for alcoholism. It could be any number of things that you can think about. So we use this definition to help our clients. So I want to give you a little bit of examples on this definition. So somebody who's ashamed and embarrassed for the family if they report their abuse. Many of our clients are embarrassed and ashamed because they think it's their job to keep the marriage together, and the role status of women is always secondary to the men. So if something is wrong in the relationship, the women are more likely to be blamed than the men. So therefore, and very informal counseling goes on. The marriage is between two families and not between two individuals. That's a huge cultural difference. In South Asia, you marry into a family, you don't marry the individual. So one of the things that not much discussed is a woman can be a perpetrator on another woman. And in the South Asian community, the mother-in-law can be a perpetrator, which is not very uncommon. So we have at least 3 cases where the mother-in-law has passively or actively engaged in abuse, either passively through the son or actively by pushing the person down the stairs while the woman was pregnant, or locking up the person in the basement, or not giving food to the individual by locking the kitchen door so that the person cannot go in and make food for themselves, or having the in-laws taking over the money earned by the victim. So those are all cultural contexts. You can't think about, just keep thinking in your mind, what would I do if I was a mainstream person? Leave, right? No, doesn't happen. Also, another component of language, I think there's a lot of acculturation pressure to know the language and to be able to integrate into the mainstream community. And many of them are ashamed that they're unable to speak the language. When you're unable to speak the language, that becomes a cultural barrier because you have to communicate. You have to communicate with your healthcare provider, with the mental health provider, with all the social services, or even your neighbor. We tell our women clients that please talk to your neighbor. Make a friend in your building and have them give you support. When you are in a crisis, they will know that you're in a crisis. They'll say, but I can't talk to them. They're English-speaking people. How will they understand what I'm going through? Or how will I communicate with them? But since we don't give up easily and we empower the woman, it does happen that we have had cases where the neighbor has called, in at least 2 of the cases where the neighbor has called after hearing some noises in the next doors with this family, and there's call the police, call the security guard, and then they were able to resolve the problem. fear and mistrust of existing service system. That was already mentioned by some of my peers here who talked about it. There are multiple other cultural reasons why immigrant and refugees don't seek services. It's not just me saying from my experience, but according to the Family Violence Prevention Fund of report on domestic violence in South Asian community in 2009, they cited language barriers, inexperience and unfamiliarity with legal system, fear of removal from the country, isolation, and lack of cultural and community awareness about the comfort in discussing domestic violence were all cited as challenges and barriers in accessing services of all kinds. We have to continuously raise awareness about domestic violence as not being the victim's fault. So that's the agenda that I would run on. That's the agenda I would like all of you to make your agenda, to talk about your peers. I'm glad that we have an EAP person here. That's another strategy for us. Many of our clients are not illiterate. They're not non-English speaking. They are in the mainstream working in technological jobs and earning a lot of money, and yet are being abused in their homes. So that's really an issue for us. I think I'm running out of time. So, I'm just kind of weaved everything in that I'm saying. So I came up with some risk factors. In your slides, you have reasons for not seeking help because of safety and security reasons, family and social norms. You have reasons that I had cited. These are all from both my experience and also personal reasons. These are like my personal experiences and existing knowledge base accumulated through anecdotal and scholarly work and research. So these are not something to say oh, she created this, so what good does it do? I want you to read it and understand. If you want to be culturally competent, and if you want to know why clients are not seeking those services, these would be the major reasons. And they're very simple concepts to learn. I want to leave you with two major things that I thought would be of importance. Also in your handout, you have Asha Ray of Hope, what services we provide. And it also has a list of things, the roles that we play as a facilitator, case manager, friend, peer, counselor, etc. You should all think about doing that if you're working in the human service organizations. The two things that I want to stress on. One, we cannot use culture as a basis for an excuse for the existence of domestic violence. First of all, victims do vary, and we need to understand whether the level of acculturation, whether they are first generation or second generation, is an important component that you need to understand when you're dealing with a client who's seeking services from you. And the second thing you need to understand is that the culture itself doesn't induce violence, but it's the perpetrator's choice to induce the violence, and lack of awareness perhaps of the victim that facilitates and continues to sustain violence. So the intersection between culture and acculturation should be taken into consideration when providing services to our victims of domestic violence. Thank you.
So I want to thank our presenters for being here today and certainly giving us some rich information on how we could go back and utilize some strategies also to connect with them on possible programs that they're implementing at the local level.